All right. Well, my computer says right at 9 o'clock. So let's go ahead and get started. And I know we'll have a few others joining us. Thanks to everyone for coming this morning and to everybody who was able to be on yesterday afternoon. I don't know about you, but I was really inspired and energized by the stories that we heard yesterday regarding everything that's being done in our region for addressing social isolation, during the pandemic and beyond. So it was really exciting. We will be sending out the materials as well as the recording from yesterday. So if you weren't able to catch it, you'll be able to watch it virtually or at least kind of take a peek through all the slides. So my name is Georgia Lean. I am a program planner with the Arrowhead Area Agency on Aging. This is our day 2 of our spring mini conference looking at addressing social isolation, the silent pandemic. And we're really pleased to have a great speaker with us this morning, followed up by a panel again of folks from different areas. We have somebody from public health, somebody from a community organization, and a mental health organization to talk about the work that they're doing with social isolation. So I see we've got a lot of folks on from all over the region, which is exciting, and perhaps even from a few outside of the region. And we will just be able to welcome more folks as they come on. Just a couple housekeeping items. Feel free to grab another hot cup of coffee or tea, whatever you need to take care of your needs this morning. And then please do keep yourself on mute so that we can avoid any distractions and feedback that are happening. And then you will see, we announced this yesterday as well, but we will be sending out an evaluation after this along with the materials. And if you are so lucky to get to do your evaluation, you're going to get a surprise in the mail from us. So we have a little present that is relative to social isolation and self-care. So please do, as a reminder, if you have to hop off early, keep an eye on your inbox to look for our evaluation and you'll get something in the mail. Who doesn't love mail these days? Real mail, snail mail in your mailbox by next week. So without further ado, I'm going to introduce our speaker. We have Dr. Joe Bianco with us this morning. He is the board certified family medicine physician and has practiced 26 years in Ely, Minnesota. He has been the director of primary care for Essentia Health for 10 years, with work focusing on new primary care models of delivery, end-of-life care, shared decision-making, health equity, and he is now the leader of the ambulatory quality. Dr. Bianco is also the director of Opioid Stewardship Committee for Essentia, addressing the opioid crisis, the vice chair of board of directors for the Minnesota Community Measurement, and the co-chair of Opioid Stewardship Committee for ICSI. So welcome, Dr. Bianco. Thank you for joining us this morning.
Yes, thanks, Georgia. And it's really an honor and a pleasure to be here with everybody. I'm looking at the names coming up on the chat, and so I know many of you. I wish we could all be in person, but this is the reality we have, and we'll be addressing that within this presentation as well. I hope to kind of set a stage for further discussion with the panel. And Georgia went over the topics and the innovations that you outlined yesterday, and it just sounds amazing of all the great work that's going on in northern Minnesota. So congratulations to all of you. So some of this might be redundant, but I'm going to try to make my goal is to help you to be able to understand a little bit better the complexities and the gray zones in dealing with social isolation and behavioral health. So, Georgia, can you pull up the slides for me, please? So we're going to talk about social isolation, loneliness, and depression. Let's see, and go to there we go. All right, next slides, please. So for disclosure, I have no financial interest in this. I'm a 61-year-old heterosexual cisgender male born, raised, and living in northern Minnesota. I grew up in Silver Bay, and I've been working in these primary care models of delivery. I don't have a sociology degree. I haven't done a lot of research in sociology. Some of the research that we've done has been in primary care. So I I think I don't have that expertise maybe that you're looking for, but I do have clinical experience of working in rural communities for 30 years. And for all of you in your communities, I always like to share these mantras because they work for me in my leadership. These are kind of what I try to live by, and it's pretty simple. Listen more, talk less, always be curious. And perfect is the enemy of good in which we're trying to get things done. Next slide, please. So Edward Hooper was a artist, American artist, who in the 1920s captured the idea of socialization in the urban settings. This picture, called Automat, was done in 1927. And Automat, interestingly enough, was like an in-person vending machine. It was a storefront, though you would go in there and there would be no waiters or waitresses to greet you. You would just simply go in, put a nickel in, and you would be able to get a cup of coffee. And I think this painting outlines the idea of this lack of social interaction for the sake of increasing modernity and increasing efficiencies. And I think this was over 100 years ago when this is done. So this issue and this discussion around social isolation has been going on for a long time. Next slide. So something a little bit more closer to home, this is a picture of the Boundary Waters area canoe area wilderness. Next slide. And in the 1930s, a young woman graduated from nursing school, but decided to go up into northern Minnesota. Next slide. And work on a family resort. I'd love to have been able to catch a lake trout like that. That's like unbelievable. Next slide. And she lived in this cabin in this resort and stayed up there even after she completed her nursing degree. Next slide. And her name was Dorothy Moulter. She died in 1986. I was a student in Ely while she was still living. And what we know about Dorothy, they called her the Root Beer Lady, is that she would live up there all winter long. People would go up there, cut ice for her so she could have ice for her refrigerator. And she was the root beer lady. She made homemade root beer, and folks would come through in the summertime with their canoes, and she would sell them root beer. She was a legend. And when the Boundary Waters Canoe Area Wilderness was created, she was the only person who was allowed to stay within that geographic area. And like I said, she died in 1986. But in the early 60s, in the Saturday Evening Post, they coined her, next slide, the loneliest woman in the United States, which is pretty interesting. And when the Saturday Evening Post wrote that, all kinds of reporters requested interviews with her. And she commented about, how could I be the loneliest person when everybody's coming up here to try to talk to me? So this idea of loneliness is pretty interesting. Next slide. And when you think about it, loneliness is really a subjective assessment. Another way of looking at this or talking about it is perceived social isolation. It's really an assessment of what the person's social relationships are and if they are lacking. Social isolation in and of itself is really an objective measure of connections to family, friends, and communities. And then you throw depression in with this. Next slide. And you throw depression in like this, and each one of these rings can be viewed in isolation, or there's that center in which somebody can be experiencing all of these things. How do we address these issues? Loneliness, social isolation, and depression. Well, we use the medical model for depression. We look at depression as being another chronic disease, just like asthma or diabetes. There's ways to diagnosis. We know that there are both anatomic and chemical changes in the body that can lead to depression. Now, loneliness we address oftentimes with a social model. What kind of interventions do we do? Phone calls, community health workers, other innovations that we do to address loneliness. And then social isolation we address what kind of community structure, safety, what kind of buildings do we build, what kind of services do we offer. And again, there's a lot of gray zones between all three of these. And it's important to recognize what is the primary driving force for the people that we take care of in order to incorporate innovations to try to help folks. So next slide. So I want to talk about, though, depression, grief, and demoralization, because I think it's really important for all of us who are working in this sphere with our elderly, and also, I think, in regard to us as just being community members, and recognize this for all ages, to be able to distinguish and to understand and to look for red flags when we're dealing with folks, because it's really important to understand the differences between these three types of conditions. Let's talk about depression first. Ole Rolvag, I graduated from St. Olaf, so everybody had to read Giants in the Earth. Ole Rolvag was an author, again, at the turn of the century. And he really captured this in this quote from Giants in the Earth. This is a story of people taming the prairie in southern Minnesota. And it's a hard story to read, just simply because of this family and what happens to this family when they're isolated out on the prairie. But I think this captures it really well from the standpoint of depression. Here was the endless prairie, so rich in its blessings of fertility, but also full of great loneliness, a form of freedom which curiously affected minds of the strangers, especially those to whom the Lord had given a sad heart. So it was interesting when I reviewed this again, is that Ole Rolvag kind of recognized that people are predisposed to depression. It can run in families. It is something that many people are unfortunately set up to have, and then there are other factors that can make it worse. Next slide. So when you're looking at making the diagnosis of depression, the first two bullet points are basically the most important. People with a depressed mood for most of the day, a diminished interest or pleasure in all activities for most of the day. And then these bullet points that are highlighted in red, the reason I did that is because you can also, this is what's listed in the DSM-5, but you can also look at these other aspects that are in the parentheses. So weight loss or change in appetite, but folks can also have kind of a depressed appearance and be tearfulness. This is just kind of an objective look at people. Insomnia or hypersomnia, but many of these folks are really kind of socially withdrawn, or they have decreased talkativeness. Psychomotor agitation or retardation, everybody just moves very, very, very slow, or they move really very fast. Fatigue or loss of energy, brooding, self-pity or pessimism, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate, or indecisiveness, lack of reactivity. These folks you just can't cheer them up. Recurrent thoughts of death or suicidal ideation or planning. Next slide. So what distinguishes from grief? Now, grief is something we see so often in our elderly person. And this happens often when somebody dies, or a friend dies, or when something changes. As we know, as you get older, it's a series of losses for many, many people. So it's really characterized by this mild sense of loss of meaning, distress, shock, feeling emotionally numb, especially when something happens quite rapidly. And then for folks with advanced illness, or you make a new diagnosis, such as a cancer, or their chronic condition is getting worse and worse. This is this preparatory or anticipatory grief, as they're realizing so many losses in their ability to get around, their activities they used to do. This is normal grieving when you have advanced illness. So when you really get worried about it is when it's complicated, prolonged, or pathologic. Often in bereaved individuals when this goes on for greater than 6 months, and you really don't see people functioning very well. And again, there can be grief associated with depression as well. And grief can be a trigger point for people going into a major depression. Next slide. And then there's demoralization. Okay, so this is the experience of emotional distress, such as hopelessness or having any kind of meaning or purpose in life. This is loss for folks. This is attitude of helplessness, failure, pessimism, lack of a worthwhile future. There's reduced coping to respond differently. There's social isolation can also go along with that, especially when people move from their own home and they move into more of assisted living or a skilled nursing facility. They can feel like they're a failure. They weren't able to make it at home. And this could be something that can be very demoralizing for people. If this is persistent for two or more weeks, then you have to be very concerned about this. And it can have features of major depression. But if those features of depression are primary, then it's most likely major depression rather than just plain old demoralization. So kind of some pearls to distinguish between these. With the next slide, please. So demoralization is, like I said, this hopelessness, this helplessness, this loss of purpose. But it's different from depression in that the patient retains a capacity for pleasure. They're still able to see family, be happy with family, and they have this ability to have this full range of affect. So they can be happy. They're not morose like you see with people who are depressed. So that's important for that characterization. And the reason I'm really focusing on making sure that we're able to characterize demoralization and grief from depression, because depression is something that we're very, very aggressive with treating in a wide range of modalities. Demoralization is best treated with psychotherapeutic interventions. A lot of the work that you do, and with support for folks, good listening skills, being able to be there for people. Now, grief and anticipatory grief is differentiated from depression as it comes in waves, often period of time. It's not pervasive. It's not there every day. Again, the key element with this, as in with demoralization, is there is the capacity for pleasure. And the patient maintains self-worth and hope. That's different than demoralization. So that's how you distinguish it from grief. And again, treatment of anticipatory grief includes active listening, encouraging, uses other elements of support. We have our bereavement groups, and I know somebody was talking about a Zoom bereavement group that's going on in one of the counties. And again, group counseling is really important for this. So in summary, it's really important to recognize depression, extremely important to recognize depression. But it's important to distinguish this from just folks being demoralized because of changes that might happen and loss that they might experience. And then also from grief, which is also characterized by loss. But again, you still are able to maintain some capacity for pleasure in your life and some sense of self-worth and hope. Next slide. All right, now I want to just kind of talk about place matters. And maybe many of you have seen this slide before that came out from the county. But this just shows mortality per 1,000 folks in St. Louis County as distinguished by zip codes. To the right box, you can see basically Duluth, and you can see the downtown area along with Park Point. And you can see that the difference between that zip code and a zip code that abuts it, the 55812, you can see this vast degree of change of mortality between these places. And then if you look to the left, you can see all of St. Louis County, and you can see the differences going across St. Louis County as well, depending upon where you live. So place matters, and it's more complicated than just being socially isolated. It has to do with questions of disparity and equity and income and access to healthcare services. But it is important to recognize that. Next slide. Now we did when we look at our rural communities, and again, I'm talking to this group because it's primarily rural folks that we're dealing with. It's also important to understand who are the most vulnerable. And in regard to mental health, rurality is a huge risk factor. Primarily, the research shows for children, military veterans, as well as the elderly. So it's important for us to create care models that address this, and we need to be more creative within our communities and in our rural settings. So it's really important to be able for our citizens to access comprehensive behavioral health services in these rural communities. And these are usually not what we're talking about. I think the ideal is collaborative care models in behavioral health that utilizes nursing, utilizes clinical psychologists, social workers, community health workers, exercise and physical approaches, the ability to discern and work in a culturally sensitive way to deal with our Native American population, as well as working with other populations as well that are victims of some of the inequalities that we have in our system. Next slide, please. Okay, so when we talk about social isolation can be geographic, it could be structural, it could be cultural, and it can be social. So, in the right lower quadrant, the young ladies who are looking at their cell phones, we recognize that is an issue right now with technology. Culturally, we can see how for our immigrant populations or for other populations in which there is not adequate equity within our society, they can feel isolated, though surrounded or by many, many people. Structurally, how we establish our cities, how we build our cities, what kind of spaces we have for people to congregate and be together are extremely important. How that urban design or rural design for that matter happens. And then geographically, again, we have wide open spaces in which people, because of their vocations, whether it's farming or whatever, they are socially isolated physically from other people. Next slide. And then social isolation comes in a more kind of micro sense because of mental health or physical problems that go on. And I think with the next slide, this is a real chicken or the egg question. Does somebody have a mental health disorder in which then they become socially isolated because of their mental health disorder, or they have a physical disorder that does not allow them to get out and be about, and they become more socially isolated? Or are they socially isolated and then they develop, because that's a risk factor, by being social isolation, because we as Homo sapiens, we know that our brains work better when we're with other people, that they develop mental health problems or they develop physical problems because they're socially isolated. So it's always really a question to design where the origin of the problem is. Next slide. The neurobiology of this, and the neurobiology of loneliness, has to do with the hypothalamus, which is in the center of our brain. And anytime there's any kind of environmental stressor, whatever it be, loss of a spouse, loss of a job, whatever, it leads to a cascade of hormones within our body that really end up affecting our adrenal glands where cortisol is made, which is kind of that hormone that really helps stimulate our body and leads to welfare of our body. It is the stress hormone that goes on. And as that cortisol is increased in our body, it leads that increasing or that constant stress that is going on within our body leads to increasing medical problems for many people. Next slide. And when you look at that, it can lead to increasing cardiac disease. It can lead to increasing problems with diabetes and depression. We don't sleep as well, which then exacerbates all these other problems as well. It can lead to increasing frailty. Long-term stress, and it's interesting what just came out recently in regard to dementia, was for folks within their middle age. Poor sleep in middle age is now being associated with earlier dementia. So you can see how these are all tied together. And subsequently, because of this, it increases mortality. And if you look at the overall system, it increases healthcare costs because all of these other conditions are worse. So by looking at social isolation as a health care problem, a problem that is upstream that needs to be addressed is extremely important. Next slide. And emotional stress, leads to other surges in mental health, such as what we're seeing right now with substance abuse and domestic violence. We've seen with the pandemic, interesting enough, I wanted to put this in here. This was in March of 2020, right when the pandemic started. This huge increase in gun sales that was unprecedented before. And what we know about suicide, and because of the lethality of guns, the greater chance that somebody's going to commit suicide if they have a gun present or they have access to a gun. So this emotional stress from the pandemic and then this association with the gun sales has led to this increasing problem that we've seen in suicides. Furthermore, what we've seen is increasing opioid deaths in Minnesota. The latest data came out last week from the Minnesota Department of Health, and we saw within the age group of about 18 to 40, 50% increase in overdose deaths. This primarily secondary to synthetic opioids such as fentanyl. But the fact is that people are utilizing substances to a greater degree, and we're seeing in this problem. Next slide. And so the reason I want to just talk about this loneliness paradox is because we think about loneliness primarily within our elderly, and I know this is a group looking at our elderly, but I want to just make you aware that there is this paradox that's going on right now, and what we're seeing in a lot of studies is that increasing loneliness that's going on is a lot in this younger age group, and they were affected extremely markedly at the beginning of the pandemic. And if you think about it, you think about these young kids going off to college for the first time, but when they go off to college, they're isolated, they're in their masks, they're in their dorm rooms doing Zoom classes, and if there is a outbreak or if there's somebody who is a contact with COVID, then they go into quarantine for 2 weeks. But they didn't have the tools even before that to manage with social isolation because they are primarily very hooked up on social media, which in and of itself seems to be something that you would think would increase connection, but actually can exacerbate loneliness. So we saw some really increases in this group, as well as increases, again, in substance use and as well as suicide. So I think it's important to recognize this. And it's important to recognize this because we're dealing with elderly folks, and elderly folks have grandchildren, and children. So that's why it's really important to talk about this. Well, for older adults who use Skype to talk to their grandchildren who live across the country, with them, we've seen this help them, right? We have seen this mitigate loneliness, whereas it's a little on the opposite side in regard to our younger folks. Next slide. So measurement, just like with depression, we use a tool called the PHQ-9 or the PHQ-2 to give us an idea of whether somebody has a clinical depression. There are loneliness scales that have been developed, and I would encourage you to look at these and use these. There's one from UCLA, and then there's the one from the Institute of Medicine, the Berkman-Syme Social Network Index. You can look these up and utilize these. But again, the utilization of measurement tools, and we use these all the time. In my work with opioids and substance use disorder, we use these tools to look at, they're basically to raise red flags, to get our attention, to then interact with the patient and talk more with the patient about what is actually going on. But they're vetted. They have been proven to be a good way to get going on your workup with folks. So I think it's important to be familiar with this and be able to utilize these within the work that you're doing. Next slide. Okay, so let's just talk about isolation now within the pandemic related to that. Next slide. So this is from the Kaiser Family Foundation, and this is looking at average adults reporting symptoms of anxiety or depression as compared to 2019 to 2021. So you see this significant increase that has gone over this period of time. Next slide. And then looking at the age groups, and again, this is what I'm talking about anxiety and depression, the differences between these age groups. And again, we're seeing this out in the morbidity that we're in regard to depression, suicide, and substance use across the country. So twice as many people in this younger age group, they're been much more vulnerable in regard to the pandemic. Though everybody has seen this increase, everybody has. We've seen it as significantly more in our younger population. Next slide. But if we talk about our elderly population, and this is from the AARP, we know that 73% of our elderly folks feel socially isolated from others. And when talking about feeling the lack of companionship, feeling isolated, having infrequent social contact, we've known that's gone up. Next slide. And within this, you can see people are sheltering alone. We know that. People have gone a long time without seeing somebody else. This last weekend, my son had a basketball tournament down in Minneapolis. His grandfather lives in North Minneapolis. The only time that he got out over the past year was to get his immunizations. And so we were able now to see him for the first time after 16 months because he was fully immunized. And it was one of the rare times that he has gotten out of the house, if not the only time, except for his immunizations, in order to take him to one of my son's basketball games. So that's a long time for not seeing somebody in person. More people, for people 50 and older, how long they're going without talking to somebody. And then also, people sheltering in place. Next slide. And then these connections, on the right, again, grandchildren are extremely important. So many people saw their grandchildren less. They feel less connected with their grandchildren, feel less connected with their friends. And these numbers are pretty high. I mean, it's a significant amount of people. Next slide. So what did we know? Well, we had to do this. We knew that COVID is and continues to be a really nasty virus with a highly contagious nature to it. So we had to do social distancing. And so congregate settings with rules and restrictions in our nursing facilities. There's the individual fear that was going on and lack of resources to help people with their fear. That's making people feel more socially distances. Relationships were challenged in regard to this. And I'm going to just put in this, is that our political polarization really also can lead to socialization. Social isolation within our families, and that's become worse, unfortunately. And it's had a lot of consequences for a lot of people as well. We sometimes fail to recognize that lack of volunteer opportunities. People are exercising less. Their healthcare was interrupted and changed from that standpoint. Oftentimes, just coming to the clinic is a way to socialize for people. We recognize that. And then again, our practices of faith and spirituality were really upset as well. So there was a whole lot that went on in regard to that. These gathering centers, where there are community service organizations, faith communities, again, volunteer opportunities, food centers, again, people where meals on wheels, not meals on wheels, but senior centers where meals are shared. And even the curtailing of meals on wheels because of social access, just the idea that somebody would come visit and talk for a little bit and drop off a meal, incredibly important. Educational opportunities for seniors and for our young folks. And then again, health-related gathering centers, all upset by the pandemic. Next slide. Furthermore, social distancing. So with this, disproportionately, what we saw, people of color, elderly, and low income. And these folks, as we know, were at higher risk of dying and did die disproportionately from COVID-19. We know that within our nursing facilities, particularly in some of our urban areas, and especially where there are larger populations of both African American and Hispanic folks, these are many of the people who work in our long-term care facilities. And again, especially when you saw their isolation, they were much more. They would still be working, but they were much more at risk for the virus as well. Masks, just by sitting in the exam room with a patient and having a mask on, particularly for our elderly, I found that patients were unable to fully understand oftentimes what we were saying because we underestimate how much our elderly folks lip read. And so I'm sure they felt a sense of isolation and embarrassment at times by not understanding. And I know that there were times where people would seem like they were understanding what you're saying, but were too embarrassed to really, kind of say what, ask, or to clarify what was going on. Then we'd have quarantine periods for people, for our family members. Then just the infectivity of this virus. And then finally, just fear. And I think we're going to see something going on now as we gradually emerge from the pandemic, is that there is, I was reading about this as I was preparing for this talk, a cave syndrome that people talk about. There's some people who are so used to have been in this isolation before, the fear of coming out again, even though it might be safe relatively to come out and safe to be without a mask outside and safe to start to congregate both at our churches and in our community centers. Some folks might not do it. And I think we have to recognize that. And that will be something that we'll have to see as we go forward. But it's going to happen. And for certain people, that they might still be very, very scared about coming back out and becoming part of the community. Next slide. So let's see, go back. Let's see. Oh, okay. So I want to talk about some innovations and ideas. All right. And so, this is work that you guys are all very familiar with. I'm not going to go too much into it. I'm speaking to the choir here. But again, if we're talking about, I had worked previously on dementia-friendly communities, and this is along that same realm, age-friendly communities. Again, outdoor spaces and buildings where people can gather and congregate or exercise. Obviously, transportation, housing, social participation, being able to talk within the community and educate both our folks working in our stores, working with our policing and public safety, and our healthcare folks, to be able to respect people as they're older, not discriminate against them, not have stereotypes about them, and to include them and to recognize what you can do in your particular establishment to make it friendly for them to come in there and easy for them to come in there. Opening all avenues to folks who are older for civic participation and employment, looking at communication, how we communicate to people and get information out so their lives can be fulfilling. And then also within our health services, being able to accommodate folks within our health services. I just get so frustrated with our clinics so often that there are these rules that in order to get health, you got to come to the clinic, which is just baloney. We need to create systems of healthcare delivery that go to where people are. That is the best way to do it. And the work that you're doing within these communities is healthcare. It's too often people think the stuff that I do is healthcare, and we know that is not true. It is primarily the work that you guys are doing really makes the biggest difference in regard to people's morbidity and mortality. Next slide. So in that light, I just want to talk about a couple things that I've been involved in. And maybe a lot of you know about this, but we have a community care team in Ely. A number of years ago, we got a SIMS grant, and we put together this grant that hired community health workers and tried to gather all those folks within our community that were providing health, whether they be at the schools, whether it be at the churches, the county, behavioral health services, food, housing, and bring everybody together in order to problem solve for individual patients, for one, and then in a larger sense, for the community as a whole, to bring all these really super smart people together to innovate, to deliver care, and to make the community as healthy as possible. Next slide. So this had an origin really looking at our children and our youth, because we knew that they are vulnerable, but being able to get a shared release of information so that we could individually create a care plan with all of these wraparound services for individuals, as particularly of the youth. But then it expanded out to a greater degree to deal with those folks with behavioral health problems, serious mental illness, as well as our elderly. Next slide. Again, the key is bringing this team together and being able to talk about individuals so that you can troubleshoot for those individuals. And then furthermore, looking at the community as a whole to strengthen the safety net within the community. And I shouldn't say the safety net, to be proactive. The safety net is just what it is, but to be proactive, to be upstream of how we can make our community better and safer for people. Next slide. So it's all about networking and learning about other services and creating relationships within that group itself so people know how to problem solve for these specific concerns. Finally, it's case management for individuals. And then again, collaborating to work on that upstream work of primary prevention. One of the keys, next slide, is our these community health workers. And I'm a huge advocate of that. We have 5 of them now in our community. And again, that innovation has been the best thing for me in my primary care practice for my patients, because they are the air traffic controllers. They are the ones who are keeping track of the patients 24/7, 365, and know all the resources in order to get those resources for the patient. What we know about patients where people fall off, where they are at the most risk, is transitions of care from going from primary care to maybe a behavioral health service, or from the hospital to the outpatient, or from the housing to the food place. I mean, those transitions, if somebody's overseeing them and helping them and making sure that they are fulfilled, is just so extremely important. And that's where this community health worker comes in. Next slide. So another innovation that we worked at, and this is particularly in the pandemic, but will live on further, is what we call our hospital at home. And last year, I read this article in the New England Journal of Medicine regarding Bergamo, which is a town in northern Italy, which was the epicenter of the COVID outbreak in Italy. And this is a picture of that community. And as you can recall, it just got hammered. And it was really sad because so many of the elderly were dying at home. I mean, dying alone within the hospitals. They basically left their home and their family never saw them again. It was extremely sad. So this article was written by Italian physicians recommending alternative ways of taking care of people. And I think this endures beyond the pandemic. So at Essentia, we created, next slide, a hospital at home. Because what do we know about hospitals? They're completely disorienting and isolating places for our elderly. And not everybody needs to go to the hospital. And there's this gray zone in between being treated as an outpatient and being treated within the hospital. And I think that gray zone is being able to bring hospital-based services directly into somebody's home, because there they are surrounded by supportive families. There are in recognized and comfortable settings. You have less. The data shows that you have less falls. You have increasing mobility. Increasing mobility. You have less delirium. So they're safer, and the studies are showing that people get better faster. There are less poor outcomes, and that there are lower costs. There's also greater patient satisfaction. So we did this in response to COVID because we wanted our elderly to not have to come into the hospital because of these, and that we could provide these services. So it's 24/7 contact with folks. It's all video, along with rounding a couple of times a day. And we're going to continue this going forward now with other chronic illnesses like low-risk infections like pneumonia or urinary tract infections, cellulitis for patients, or exacerbations of congestive heart failure or poor diabetes control. So we can take care of people now within their homes who are elderly with the support that they have there. And we worked, as we started to work on this, this can also be associated with our communities and our community of health workers in order to get services brought to the home when the patient might not be able to go grocery shopping or get other things done. So this is something that we're just getting going. And I think this is something that can also help with the isolation that comes within the hospital, but also isolation at home when somebody is not feeling well. Next slide. So for our healthcare systems, it's really important to develop a robust evidence base regarding loneliness and social isolation. Translate this research into healthcare practices, like I think we're doing with some of these innovations I just talked about. I think it's really important to improve awareness. I'd like to talk about loneliness and social isolation as chronic diseases because they are chronic diseases for many people. And there are some very important tools that can try to help them. Again, strengthening education and training around this. And then again, this work of taking the healthcare systems and community-based networks, embedding them all together in these community care teams. Next slide. And other interventions that we know, volunteer visiting, phone calls. We're doing medical group visits now for chronic pain. And just just getting people together on Zoom, talking about chronic pain. We know we have the Juniper work that's going across the state, dealing with chronic pain as well, living and chronic diseases that are available with the Zoom visits on with Juniper. And at some point, we'll get back into in-person group visits as well. And I do think that the evidence shows that these improve people's well-being and health as well. Co-location of care delivery. These skilled nursing facilities that also have daycare present there, in which our elderly mixed with our youngest, I think are incredibly important. And we do know that there are daycare shortages in many of our communities. And so I think looking at innovation that ties these two together can solve two problems at one time. So I think that's really important. And we know about grief support, and I can't emphasize enough the importance of veteran support within our communities as well, especially within our rural communities in regard to our vets. And then education on social media and its proper use for all of us, myself included, how best to manage social media because it's pervasive. And we need to be able to teach our kids at the earliest age what our best practices and how to use social media, and not use social media as the socialization tool. Rather, Homo sapiens, we all need touch, and we need face-to-face, and we need care and expression outside of the screen. And we need to teach each other how best to do this and to learn best practices about this. Next slide. And then there are policies. Again, improved mental health services, improve the public access, public response to COVID-19. And this is my plug as a primary care physician: get immunized. And please get immunized and help people to try to understand the importance of immunization if they're hesitant, and educate them about its importance. Again, the Older Americans Act, improve programs for that, and enhance our nation's education system. These are all, this comes from this coalition to end social isolation and loneliness. These are policy considerations. Next slide. So that's my presentation. What questions you have? I was not looking at the chat. I don't know if anything came in, but feel free to ask any questions.
Well, I see, I'm going to try to scroll up here. I think an initial question kind of earlier on in your presentation was around the zip code question. Yes. And a question around, I get that place and socioeconomics matter for mortality, but the graphs like the one don't take into account age. Right. So can you speak to that maybe a little bit in terms of how that might factor in or doesn't?
Well, again, age matters from the standpoint of that one slide that I had in regard to socialization, in regard to mental health and physical issues that go on. And then also in regard to, I think the other one that comes in is how far people have gone in regarding creating age-friendly communities. So that's where place matters from that standpoint as well. If people live in areas that don't have transportation or don't have the infrastructure that make it easier for people who are older to get the services that they need. I think, and that can vary from place to place to place.
Great, thanks. And folks, if you want to ask a question, feel free to type it in the chat or just unmute yourself and turn your camera on so we can have a little bit more face-to-face.
Dr. Bianco, this is Christy Kane. I'm wondering if you can talk just a little more to the hospital at home efforts and what are you seeing in terms of growth trends and kind of distance from the Duluth Central area? Are you reaching the very deep rural populations, or what does that look like right now?
Yeah. So we are rolling this out. We at Essential, we're kind of across northern Minnesota over into eastern North Dakota. And so we're rolling this out in the Fargo-Moorhead area, but it is available within our smaller communities out there. We have the equipment in Ely right now, but we're still learning some of the nuances of this. So our plan is to bring this into all of our communities going forward. It will have some, the nursing will be centralized, but there will be tying into the local community primary care center as well. So that's what we're hoping to roll out. The data in regard to this and the studies are primarily from the East Coast. And what we've been seeing is that, again, it really is shaping out to be something that is going to be, I think, it's going to be how we deliver care in the future. Mm-hmm. We are negotiating right now at Essentia, and I think we're completed with it for Medicare to fund this. So it will be covered by insurances and most insurances, and because people are seeing, again, the triple aim in improve quality, patient satisfaction, decrease cost. And I think it's going to be something that'll be there for the future. The key for hospitalization at home, I should mention this, is discerning who will, for whom they will do best with this. So it's really important to choose the right patient. For the folks we've had so far, we've made that right choice 85% of the time. There have been people we've started off with hospitalization at home, and that's 15% that then had to transition to the hospital. It wasn't going to be successful there. So that's, but 85% is pretty good for going first time around and being able to distinguish who would be best for that program.
And how do you see that, or do you see it at all, kind of melding with telehealth?
Well, it's all telehealth. The patient goes home with an iPad, and then with 24/7 access to a bank of RNs. And then there is internal medicine clinicians as well as primary care clinicians who are able to turn on the screen and talk to the patient and have them get up and move around and that type of thing. So, and then they have computer generated temperatures and blood pressure, pulse, O2 sats. And then for phlebotomy, if we need to look at any blood, we send somebody out to draw their blood.
Thank you.
So kind of a follow-up question. First of all, we had a comment from Silver Bay that from Lisa Baz that Silver Bay is very distant and medical systems are becoming even more centralized. So just I guess a note of kudos in terms of the need for this. And then the 24-hour rounding, and I think you spoke to it, but does it rely on the caregivers or person to assist?
No, again, well, there are caregivers to assist. I think one of the roles that we might see develop within the healthcare system would be hiring somebody in to go out. But this doesn't work if you're like somebody's isolated by themselves in their home. You still need maybe a spouse or somebody to be there or a friend to be there. But I do think as we go forward with this, there will be a role of a companion that we would hire in the event that somebody is isolated by themselves. Again, this is in its infancy, but when you're looking at the cost of going into the hospital, the risk of going into hospitals, because hospitals are not safe places, that it would be better to hire a companion to be there with somebody. during a short period of time to get them turned around in regard to their chronic disease.
Great. And then switching gears a little bit, a question about sleep. In regards to poor sleep at younger ages leading to an increase in dementia, is this due to sleep apnea or just fewer hours of sleep or highly disruptive sleep at night?
Yeah, I think it's both. We know that obesity is going up. And so obesity leads to obstructive sleep apnea. So people sleep less. And obstructive sleep apnea is not diagnosed in a lot of young people. So making that diagnosis extremely important, especially for those folks who are overweight. But the studies show that just lack of sleep, not enough hours of sleep. And again, that's sleep hygiene, and that's just a number of hours of sleep. And that's what the study just recently showed as being a source of perhaps early dementia.
Great. All right. Any other questions or comments for Dr. Bianco?
I just would say thank you. This was fascinating.
You're welcome. My pleasure.
Yeah, absolutely. I think it's always a great opportunity to frame the work that we're doing in terms of, I loved what you said about what the community-based network is doing really is medical care. And that's such a significant paradigm shift. And we've had the opportunity to see it, but need to continue to shed light on it. So yeah, lots of kudos in the chat about impressive presentation and great speakers. So thank you so much, Dr. Bianco. You are welcome to stay on. We are going to shift gears a little bit here. We're a couple minutes ahead of schedule, but that's fine. We can have a little bit more time for our panelists. Dr. Bianco did mention our Juniper classes. And so we are going to invite Gina Marsala, who is our current Juniper coordinator for the region, to lead us through a little 5-minute wellness break. And we can also take this time, if you need to take a bio break or go fill up your coffee, use that just to get your blood moving a little bit. So if we can hand it over to Gina.
Perfect. So we're just going to do those stretches again this morning. Get that blood flowing after that great presentation that we just had. All right. So to start off, I just want everyone to take a couple deep breaths in through your nose and out through your mouth. All right, and just nice and relaxed in your seat. We're just going to start with that ear to shoulder again. So sit up nice and tall, feet on the floor, and just ear to your shoulder. So you should feel a nice stretch in the side of your neck. And then back to center, and then we'll go the other way. Back to center. Then we'll do it one more time on each side. Like I mentioned yesterday, if anything hurts, just stop that movement. Then back to center. And the other side. And then we'll do some shoulder rolls. So you can start off nice and small. And then as you go on, just increase the size of those shoulder rolls. Try and get about 5 to 10 in each way. We'll switch in a second. All right, and then we can switch and go the opposite direction. All right, the next one we'll do a forearm stretch. So you'll just grab your fingertips and just pull them back gently. So it looks like this. You should feel a nice stretch throughout your palm and then your forearm. All right, and then switch hands. All right, perfect. And then next let's go into some wrist rolls. So kind of like a figure 8 motion. Perfect. And then next we'll go into our chest opener. So open up that chest. Since the majority of us are probably sitting, we tend to hunch over. So I'll just turn to a side view, but hands behind you, interlock your fingers, and then just kind of push your shoulders back and really open up that chest. You should feel a stretch in your shoulders and in your chest. Great. Next, we're going to stretch out the spine a little bit. So sit kind of all the way back in your chair. You're going to put your hands underneath your legs and feet flat on the floor. Sit up nice and tall, and then you're just going to put your chin down to your chest. And you should feel a nice stretch all along your spine. All right, next, so we'll go into a spinal twist. So you're going to take your one hand, put it opposite leg, and then just kind of grab the back of your chair behind you. If you don't have a back on your chair, you can also grab the back of the seat as well. And then just try and see, look back as far as you can. And then we'll switch and go to the opposite side. So the other hand on opposite thigh. Then just reach behind and then look behind as well. All right. Next, we're just going to do a side stretch. So you're going to take your one hand, put it on the side of your chair for some stability. And then other hand, we're just going to reach up and go over to the side. You should feel a nice stretch in your side and then even through your arm. All right, and then we'll switch. So that other hand opposite or next to you on your chair, and then just a nice stretch over. Right, great. So next we're just going to do a little leg stretch. Also helps with your lower back. So you're going to place your leg over your other knee. And then sit up nice and tall and just hinge forward at your hips. You should feel a nice stretch in the bum area, back of the leg. All right, and then we'll switch legs. Remember to sit up nice and tall and then just hinge forward at your hips. Great, now we'll just go into some ankle rolls. You can't see mine, but just go one direction between 5 to 10 times. And then switch and go the other way. Great, and then we'll just finish with a couple deep breaths to finish. So in through your nose and out through your mouth. Perfect. Hopefully we got your blood flowing and a nice little warm up for our panelists.
Thanks so much, Gina. Now I'm going to invite, I think we have a few panelists here to chat with us today. And Brenda, are you able, our panelists, can you guys please turn your camera on? We have Casey Johnson with Carleton County Public Health, Cheryl Champion with Insight Counseling in Duluth, and then Marilyn Osepik with AEOA Senior Programs. So we're going to get these folks up and running. All right, we've got Casey, we've got Marilyn, and we're waiting for Cheryl. There we are. All right, great. Well, thanks so much for joining us. And we are as similar to kind of what we did yesterday, although we're able to dive a little bit deeper in terms of what you all each are doing to address social isolation and mental health. And so I have a few questions that I'm just going to plug into the chat here for each of you to speak to. And in terms of how has social isolation and mental health issues manifested themselves, what have you seen in your setting? What approaches are successful for prevention and intervention? What unmet needs do we have? And then who are the partners that you are working with in addressing needs for where are there additional partnership opportunities? So I think what we're going to have, we have about 35 minutes here. So I'll maybe give each of you somewhere between 8 and 10 minutes to share, to speak to these questions, and then we'll have time for Q&A afterwards. So why don't we go ahead, let's start with Casey Johnson. I'll let you introduce yourself, then just give you the floor to take it away.
Hi, can you hear me okay?
Yep, we can.
Yes, I'm Casey Johnson. I'm a public health nurse from Carleton County Public Health and Human Services. My primary role is actually a care coordinator with long-term care unit. With COVID-19 response, we initiated our incident command structure, and I am now the long-term care subject matter expert and liaison, as well as subject matter backup for the county vaccine coordinator. So thank you so much for having me today. So I'll just dive into the questions. I just got a couple of notes here. So we have pretty good partnerships with all of our long-term care facilities, as well as home care agencies and what have you. And because we have a strong care coordination passion and background, we've unfortunately seen firsthand how social isolation and mental health issues have really impacted. As Dr. Bianco did a wonderful job explaining the physical impacts of social isolation. And we already knew about socially isolated people, that they can have higher rates of dementia, heart disease, blood pressure, depression, and cognitive declines. But specifically that depression, anxiety, and social isolation, unfortunately, they're not new. We were already seeing them in our long-term care world, whether like Dr. Bianco did great about grieving that transition from home to moving into a nursing home or even into an assisted living, or lots of people living on their own because their loved one has passed away the last few years. This is all pre-COVID. And then when the restrictions came down and what most often our folks refer to as the lockdown in spring, and it just brought a whole new level of impact. And it ended up being quite detrimental to a lot of our elderly folks. And so, because I apologize, we have a sensor in my conference room. Hold on. So not to mention the people that were already experiencing these symptoms, they manifested into worsening symptoms. I have a couple of just a really quick story to share with you. I've been working with a client for several years. She lived in an independent living situation. Initially moved in because her husband needed more of the care, and no longer they couldn't be at their home just because minor forgetfulness. She was orientated to place, sometimes not time, but doing really well when the restrictions and the lockdown happened. It was only a matter of a few months, and increased cognitive decline, increased memory loss, manifested into paranoia, attempts to elope the facility, really just an absolute spiral. And it wasn't until later in the summer when CDC and MDH allowed our facilities to have essential caregiver visits and compassion care visits, where, a facility could designate someone in like a loved one or a friend in their life to come in at a certain amount, certain time of the day. They'd have to don in full PPE, get screened, but at least it was just a little bit of a visit of a face-to-face. But that wasn't until late summer, really, when those were approved. So you had a lot of people who were doing quite well on their own, but you saw this dramatic impact. And it was detrimental she really never bounced back and now resides in a memory care unit. It was quite heartbreaking, I think, for a lot of us. That's just one example, several others too. And I'll kind of go into interventions here in a minute, but overall, that's a lot what we saw, along with decreased physical mobility, the inability to walk up and down hallways, even in your facility, or maybe even feel comfortable enough to walk around your block or around your neighborhood. Just there was that overall fear across everywhere, and a lot of people couldn't leave their room because whether it was an outbreak happening or something like that, and along with the cognitive decline, there was that physical mobility decline, and it just overall, just sort of, like I said, a spiral down. As far as what we've been hearing and seeing and biggest concerns, Dr. Bianco talked a little bit about this. So in October of 2020, AARP did a large study in collaboration with United Health Foundation, and they indicated that 2/3 of adults reporting had experienced social isolation. So this isn't just in long-term care. And then that only 11% had actually sought help from a medical professional, and almost 1/3 of those over 50 didn't look to anyone for support at all. So I feel like that, that's what we were seeing across the board for folks living in their home, folks living in facilities. But, I kudos to our facilities. So too, they were trying to find a balance of having to keep people safe, right? Because we always look at like Maslow's hierarchy in nursing. So you want to make sure you have your shelter, your warmth, and then you have your safety and security. But really those psychological needs are halfway up your, Maslow's hierarchy. So, but interestingly enough, they start to cause kind of a trickle effect. So the failure to thrive following social isolation and increased depression ultimately impact their physical health, and needing to address those is really what we were starting to see. I guess a bit of optimism, though, as what we're seeing is just the fully vaccinated guidance changing, and the ability that once you are fully vaccinated to have more physical interaction, to paint a picture in a facility. Even when you had a compassionate care visit, your loved one would come donned in full PPE, face shield or glasses, mask. And for a lot of those who were hard of hearing, they couldn't read your lips. And I don't know, a lot of us have personal experience. When you see your mother or your grandparent, you want to give them a hug, maybe a kiss on their forehead or hold their hand. And we lost a lot of that. And we all crave that. Even those that maybe are more recluse to their room, or they are naturally socially isolated, even they, really needed that. So just overall trends, like I said, just to paint a picture of what it is still really like in those settings. But again, a bit of optimism is that fully vaccinated. So our public health campaign, we're really focusing on vaccinations. We've had to switch gears, but fortunately, Carleton County, I am happy to report today, we have 97% of our 65 plus have been vaccinated. So really good news there. I guess a concern coming down the plank is the fall, and just the worry about having to dial up again as the governor talks, or just the masking and the changes, and obviously big picture too is another pandemic or another wave. I think that's a big concern on all of our hearts is how our elderly population going to be able to handle a long winter, a very long winter of not being able to see loved ones. Should I keep going? So a couple of approaches to successful prevention and interventions that we found with some of the CARES Act funding that a lot of local public health and a lot of agencies were able to receive from the government. We had wonderful support from our human services director, and we actually created not only a long-term care branch, but a behavioral branch under our incident command here at Public Health, just to be sort of just a spot for people to call in, have questions, whether it was business owners, like I said, long-term care facilities. We provided outreach to all of our nursing homes, adult foster care, and assisted living, pretty much this whole pandemic. But with that being said, there was an opportunity to, how do we support financially or in some capacity our facilities? And we purchased iPads for all of our assisted livings and nursing homes, because a couple don't have the technology updates really, or have been able to spend that money. So being able to provide them with an iPad where their residents could use, just set up in a conference room, and residents could come in and talk with their family and or utilize it for mental health services. We found that was a real success story too. And then we were also, for some of our dementia or memory units, we were able to purchase some animatronic pets. And I don't know if, I won't go into them now, but if you Google animatronic pets, they're just they're an absolute wonderful intervention for folks who are cognitively moderate impaired. It's a life like has motion and is life like a cat or a dog, and really wonderful, heartwarming stories we've heard back from that. So as far as that, unmet needs, I am absolutely over the moon about the hospital in the home. I hope we can reach out to our partners too, especially with care coordination and case management, not only at the county level, but senior linkage line. They have sort of had a huge, I think, and I know Brenda, I don't know if you guys speak to that too, but senior linkage line has really stepped out and really doing a lot of PR and showing that, hey, we are also a one-stop shop. We could possibly even do some case management and get your support to get visits or other resources, and as well as direct them to your local public health, human services. And so I am really excited to hear about the hospital in the home and maybe a partnership, because I really feel, unfortunately, unless you had a good connection with a mental health provider where they felt comfortable doing like a FaceTime, or if there was an iPad in a facility, you could coordinate that with either a nursing assistant or a loved one would set that up for you. But the rounding aspect of a provider to be able to see someone more readily is really lacking still. So I can't wait to hear more about that. That I love attending these and having a couple takeaways. So that's my big takeaway today. I think that's really it. I hope I didn't go over my time. Apologize.
Oh, you're right on. So thanks so much, Casey. Really interesting to hear. And I think we've all had personal stories and heard about the challenges faced in long-term care. And just my heart goes out to the residents and to the dedicated staff who have worked with them every day and doing the best that they can, given the circumstances and requirements and restrictions that were put in place. So thanks, Casey, for sharing that. And we're going to switch gears a little bit and switch over to community side. I'm going to ask Marilyn from AEOA to introduce yourself, and then take about 8 to 10 minutes to talk about questions.
Hey, I'm Marilyn Olsepik. I work at AEOA. AEOA's Senior and Nutrition Services Department. And our largest program in that department is congregate and home delivered meals that covers the 7 counties of the Arrowhead region. We also have a grocery program that covers northern St. Louis County. And in my department is food access. And that's a new kind of service that covers a food forest in Virginia. It covers the farmers market and provides EBT access at the farm at 4 different farmers markets. And the community gardens, there's just a whole realm of working with small farmers that division is doing. So on this topic, because congregate and home delivered meals is our largest, we have about, I'll roughly say 8,000 participants in the 7 counties. And so what we did was we concentrated on our home delivered meals and our grocery participants, and kind of develop a list of initially 500, and then from 500 went to 1,000 to 1,500. And during the COVID, we had people working remotely. Some people might have been even on layoff during that time. But our partnerships were in-house partners from other departments, Head Start, housing folks, and that. And our planning department developed a survey, and it was on SurveyMonkey. So when we called people, that's what we were planning on doing, is calling folks from those lists, from our participant list. And so the SurveyMonkey kind of had a script, introducing themselves to, the client, and had several questions, and starting off with, are you currently able to access all the food you need? Do you need help getting groceries? Are you able to prepare your own meals, or do you need prepared meals delivered to you? Would you like assistance applying for SNAP, food stamps? And do you have any other needs? And we will be working with other entities to connect you with services you may need. And do we have your permission? And like I said, we started up with 500, and when we finished with the 500, we moved to the next 500, and again to the 1,500 total then. And not everyone participated. I'm not sure if we did a lot of callbacks. So what I'd like to tell you next is the results of the survey. And so we had 1,500 calls. Some, like I said, didn't want to proceed with. So the question: are you able to access all the food that you need? Only 1,000 answered that, and almost 500 said that they'd rather not. And for accessing food, 98% said that they were able to access food. Do you need help getting groceries? About 9.5% said they needed help getting groceries. And the next question, are you able to prepare your own meals, or do you need prepared meals delivered to you? Most said, 97% said that they could do their own meals. Would you like assistance applying for SNAP? 6.6% said yes, they wanted help. And what I'd like to say is, with all the questions, if they said they needed, what was that?
Sorry, please, everyone, if you can mute yourselves, we're getting a little background noise.
Oh, okay. So if they said they needed help in any of these areas, if it wasn't in our regular service area, we referred them to other partners. Like for SNAP, our agency does provide SNAP application assistance. So we have an in-house person here, but we also have our adult education instructors that can help with SNAP application. And for older folks, it's a short form. And so we could do that, via telephone, or if they had computer access, we could set it up that way. If they needed a grocery assistance, for instance, in Itasca County, we contacted Elder Circle, or in Duluth, Agewell Arrowhead. And then there was, do you have any other needs that we should know about? And one of the things that I wanted to mention is that there were quite a few people, I would say maybe 1/3 of the clients said that they would like getting telephone reassurance calls. So we didn't call all of our 8,000. We were able to call 1,500, but I would say 1/3 wanted the telephone reassurance, and we have not really followed up on that. We have gone around and around a little bit with telephone reassurance and how to set that up. And kind of worked with the Northland Foundation to set up the groundwork on that. But I don't know, staffing, and I don't know, maybe I'll just say, we haven't gotten it really off the ground. And maybe this is something that we should look at further down the road, whether, we could do it with volunteers, or maybe setting something up with some of the folks calling each other and setting it up that way. Doing a daily check, morning check on folks, and just visiting. And I'm not sure, but that seems like during this COVID, that seems like something that's necessary. What I also mentioned from yesterday's presentation is, during the whole COVID, our agency has participated in a food distribution. And I think tomorrow will mark that we'll have our, I'm not sure which number it is, but we'll cross over the 2 million pounds of food that our agency has distributed. And when we talk about social isolation, people come through the lines, they stay in their car, but I have participated in, I would say, maybe 92 or 3% of those distributions. You get to know the people. You are visiting, and from the last time that the people have come through the line, it's really important. I mentioned a client that that I knew, and he had lost his wife. So it's that connection, and I do stay a little longer to visit, and that has happened with a lot of the volunteers. You get to know people. And it is, with everyone working remotely, the food distributions have been great for our employees, even that, we wear masks and that, but there's a camaraderie, and which is really important for that social aspect of your life. And so the calls, again, I'll say, are real important. We did do calls about a month and a half ago, maybe it's been a month. And called our folks in northern St. Louis County regarding the vaccine, and to see if they needed assistance, or if they had they gotten the vaccine, do they need assistance getting the vaccine? And again, that was another social aspect for folks to hear someone, on the phone, if nothing else. But our grocery program and our home delivered meals are real important for the social aspect. During the whole pandemic, we have continued to offer hot meals Monday through Friday. We have not, yes, some volunteers dropped out, but others came forward. We haven't struggled too much with the volunteer aspect, which I am very thankful for, that our folks have been, able to continue to get the hot meal, it's not necessarily the same contact. They're just dropping them off at the door. They're not necessarily, coming in the house. The grocery program, again, that program, like others, has increased during the COVID, time. And, people that probably could maybe have gotten their groceries, don't want to go into the store. So that has increased. But it is a social aspect to their life, is to get that call from a staff person. Do you need a grocery order? To the person who delivers their groceries. I just started delivering groceries to someone in my area, and she's 94 years old. And you know what? It so happens, because again, a small town, I know one of her sisters, and I think I worked with her other sister at AEOA when I first started. So I'll have something to talk about this afternoon when I deliver her groceries to her. So I think that's the gist of mine.
Great. Thanks so much, Marilyn. It's really amazing how the volume of services you provided, and 2 million pounds of food. A year ago, we never would have thought this is what we were going to be doing, and this is what we're going to be up against. And just the non-traditional ways that we utilize this meal delivery network to even do vaccine outreach. I think that's been amazing, and just testimony to how we have really, in our region, rolled up our sleeves and done what's needed to be done. And also the acknowledgement that we're all limited in our time, our money, and our oomph, as Marilyn said. We all only have so much oomph. So it's important for us to be, as human service workers, to think about our own needs and our own, how do we not burn out? How do we take care of ourselves, take care of our team? I think that is just also, when we speak to social isolation and mental health, our own needs are equally as important as the people in the community that we're working with. So, well,
one more thing I wanted to say, that yes, we've done the parking lot distributions, but we've also loaded AEOA buses and sent the food out to different partners in the 7 counties. And that's been the USDA, the Families to Farmers, Farmers to Families food. And but we also did shelf stable and kits initially, and we did the 5, 7, and 10 kits. And the last one that we did in January through March of this year, we had a number of partners throughout the 7 counties that Age Well Arrowhead, they were our first delivery in January. They took 200. Again, that they have people that they work with that they can get those shelf-stable meals to kits to individuals. Again, that's another connection. It's not our direct connection, but it's our partners' connection with those folks that they work one-on-one with. It's United Way of Carleton County, Cloquet B&B Market, up on the shore, a number of different places. So International Falls in the college area there in the parking lot. So thankful, to our partners out there again.
Absolutely. That really speaks to that last question around partnerships and how we saw that network just spread. No one organization could have done that volume. But when we started to pull those folks together to say, okay, food access is a primary need, and really just saw the network come together.
Absolutely. I was just going to add to, that's essentially, if someone had recently had an infection, when you're asking for essential services, do you need essential services? You're going to be isolated in your home now for 2 weeks. And food is always that. It's one of the biggest ones. Food and medications, right? I had to add one more thing, Marilyn. The home visits, even if it's dropping a meal off at the front door, how important those are. I don't know how many times I've gotten a phone call from a driver or from the agent say, hey, Casey, gosh, we were at so-and-so's house and the meal was there, still there. Or yeah, you're right. So even if it's just dropping off and not actually connecting with someone, it's a safety check, and they're invaluable. So thank you for all that you've done. And we totally enjoy your partnership too as well. So thank you.
Well, thank you for that compliment.
Great, thanks. And last but certainly not least, we have Cheryl, who is with Insight Counseling in Duluth. And so Cheryl, can you introduce yourself a little bit and speak to the questions in the chat?
Well, I'm old, as you can see by my gray hair, so I struggle with technology. And I happen to be calling in from my kitchen because my old dog had surgery yesterday. So if you hear snoring, it's because he's on pain meds. Insight Counseling was founded 3 years ago, and we have grown by leaps and bounds. And when we first applied to be credentialed by insurance agencies, they said, oh, we don't need any more therapists in Duluth. And we were like, I beg your pardon. And we went through a big, kind of study of how hard it was to get an appointment. And it turns out many therapists in the cities say that they provide services up here on the range in Duluth and that they drive up, and they don't. We all know that isn't true. So hence we're open. And once we got started, we got calls from way out on the range, people from International Falls and Cook County, and we've opened a Virginia Hibbing office, and people are asking us to open more offices because I think getting access to mental health